Welcome to the Atrial Fibrillation Institute. At the Atrial Fibrillation Institute, we have a group of highly trained cardiologists, cardiac electrophysiologists. We have undertaken specialist training beyond our normal cardiology training. This is in the area of cardiac rhythm abnormalities and their management. Atrial fibrillation, commonly known as AF or AFib, is a common condition that affects us more and more as we age. As we get older, the incidence goes up. In fact, by the time we reach the age of 80, 1 in every 8 to 10 of us will have experienced atrial fibrillation at least once in their life. That is, 500,000 Australians have been affected by atrial fibrillation. Atrial fibrillation can be highly symptomatic. You can have many symptoms ranging from palpitations, tightness or chest pain, breathlessness, general fatigue, exercise intolerance, but some patients have absolutely no symptoms related to their atrial fibrillation. Nonetheless, the atrial fibrillation does carry increased risks of clots and strokes and needs to be appropriately managed so these events do not occur. What is happening in atrial fibrillation? Atrial fibrillation is a rapid, chaotic rhythm involving the atria, the top chambers of the heart, the priming chambers of the heart. The natural pacemaker sits on the atria and sets the heart off on a regular basis. But every cell in the heart has the ability to beat for itself. And when atrial fibrillation occurs, all the cells in the atrium are trying to beat simultaneously. It is chaos. The atria are beating 3 to 4 to 500 beats per minute. The ventricles, the main pumps of the heart, the chambers that pump the blood around the body, try to keep up with the atrium. The rate of the ventricles, and therefore your heart rate, will vary depending on many things. It will depend on how the natural electrics of your heart conduct the rapid chaotic rhythm from the atrium to the ventricle. It will depend on various medications which can slow that connection. And therefore your pulse rate may be anywhere from 30 to 40 to 80 to 180 beats per minute in the ventricles. As the atria are racing chaotically at 300 to 400 beats per minute, blood can stagnate. It's not being pumped on particularly effectively. And that stagnant blood can clot. Those clots can break off. Those clots can float anywhere around the body. We call it an embolization. They can go to the leg, to the kidney arteries, or to the brain. And the biggest concern or risk in atrial fibrillation is this risk of clots going to the brain and causing a stroke, a cerebrovascular accident. Sometimes the atrial fibrillation comes and goes. It may last for minutes to hours. We would call this paroxysmal atrial fibrillation. Sometimes the atrial fibrillation will persist. It may be there for days or weeks. It may require medications or even an electrical cardioversion to reset your heart back to a normal regular sinus rhythm. We call that persistent atrial fibrillation. Sometimes the atrial fibrillation continues for years. This is known as long-standing persistent or permanent or chronic atrial fibrillation. Some people with long-standing persistent atrial fibrillation or permanent atrial fibrillation will have very few symptoms. They may be quite comfortable staying in atrial fibrillation as long as we control the ventricular response rates, that is the heart rate, the pulse rate, and reduce the risk of embolic events, particularly the risk of clots and strokes. We can leave these people in atrial fibrillation for long periods. If you do have palpitations, it's important to try and document the arrhythmia. An electrocardiograph, or ECG, is the easiest and simplest test that we can use to help document atrial fibrillation. Of course, you may not be in atrial fibrillation at the time the ECG is performed. If you do have sustained or prolonged palpitations, it is important to present to your local doctor or the emergency department to have an ECG performed promptly so that we can try and document the atrial fibrillation. Of course, this is not always possible, And we can use other techniques to try and document the atrial fibrillation. This would include a 24 or 48 hour Holter monitor, a small device that you wear around, and it records your ECG over the 24 to 48 hours. It records every heartbeat so we can see if there are episodes of atrial fibrillation. Nowadays, technology has given us a number of other options. The wearable technologies such as an Apple Watch, a Samsung Watch, a Fitbit, or an AliveCore Cardia device. These wearable technologies can be used by you at home to document the episodes of atrial fibrillation. This can be very useful to confirm the presence of the condition and then help manage it. Patients with atrial fibrillation need further cardiac assessment. We need to make sure the heart is normal. This would include an echocardiogram to have a look at the heart function, the valve function, and often an exercise stress echocardiogram or similar functional testing. Other investigations that we do utilise include transesophageal echocardiograms, where under an anaesthetic you swallow a small ultrasound probe so that we can better visualise the heart, the function and the chambers of the heart to see if there's any evidence of thrombus, clot, in the atrium. Another investigation that we commonly use in our patients with atrial fibrillation would be a CT scan of the heart, a CT coronary angiogram, at which time we model the left atrium. Modelling of the left atrium is very useful for us, particularly if we need to proceed with atrial fibrillation ablation procedures. Next, we would like to talk about what atrial fibrillation means to your health.